Hey everyone, today we're diving into the essentials of managing alcohol withdrawal syndrome, or AWS. This is crucial for health professionals to ensure safe and effective patient care. First off, set clear goals with the patient. Whether it's reducing drinking or achieving complete abstinence, behavioral therapy and nutritional support are vital. Address any malnutrition with multivitamins, especially thiamine at 100 milligrams daily to prevent Wernicke-Korsakoff syndrome. Next, assess the severity using the CIUA scale. This helps you determine how intense the treatment needs to be. Now let's talk about what happens in the body. Chronic alcohol use overstimulates the GABA system and downregulates glutamate. When alcohol intake stops abruptly, GABA activity drops and glutamate spikes, causing symptoms like anxiety, tremors, seizures, and possibly delirium tremens. Evaluate your patient thoroughly. Key history includes the last drink, previous withdrawal complications, and any co-ingestion of substances. Labs should cover a comprehensive metabolic panel, blood alcohol content, serum electrolytes, and liver and kidney functions. Physical exams should check for tremors, sweating, confusion, and vital signs like tachycardia or hypertension. For mild withdrawal, CIUA score less than 10. Common symptoms are mild anxiety, tremors, and sweating. Gabapentin works well here, starting with 300 milligrams every 6 hours on day 1, then tapering over 4 days. If gabapentin isn't enough, consider lorazepam 0, 5 to 2 milligrams as needed. For moderate withdrawal, CIUA 8-14, symptoms include sweating, tremors, elevated BP, and mild confusion. Continue with gabapentin and add lorazepam 1 to 4 milligrams every 4-6 hours, adjusting doses using the CIUA scale. Severe withdrawal, CIUA over 15, is where things get tricky. Symptoms can include seizures, hallucinations, severe autonomic instability, and DTs. Here, benzodiazepines are your main line of defense. Use lorazepam 2 to 10 milligrams of 4 every 4 hours, titrated to symptom control. For rapid symptom control, diazepam 5 to 10 milligrams of 4 every 15 minutes is effective. In patients without severe liver disease, chlordiazepoxide 50 to 100 milligrams every 4-6 hours can also be used. Phenobarbital is another option when benzodiazepines aren't enough or are contraindicated. The loading dose is 6 to 12 milligrams per kilogram IV divided into 3 doses every 3 hours, followed by maintenance doses. Always monitor for respiratory depression or sedation. Adjunct treatments include thiamine 100 milligrams IV IM for 3 days and multivitamins daily. Severe withdrawal often requires 5-10 days of treatment. Special considerations include treating alcoholic hallucinosis with lorazepam or haloperidol in severe cases. Delirium tremens is a medical emergency needing high-dose benzodiazepines or phenobarbital and close ICU monitoring. Monitor vital signs and the CIUA scale closely. A CIUA score above 20 requires intensive monitoring. Upon discharge, taper medications to avoid rebound symptoms. Continue nutritional support with thiamine and multivitamins and ensure follow-up with addiction treatment services. In summary, manage mild to moderate withdrawal with gabapentin and lorazepam, and severe cases with high-dose benzodiazepines or phenobarbital. Don't forget the crucial role of thiamine and multivitamins. That's it for today's breakdown on managing alcohol withdrawal syndrome safely and effectively. Thanks for watching, and remember to like and subscribe for more healthcare insights.